Hi everybody, we'll be covering everything you need to know about age-related macular degeneration in context of the Pebc exam. Everything that's contained in this lecture is the only thing that should be tested on the Pebc exam. So let's get started. Okay, so age-related macular degeneration is the leading cause of vision loss in the elderly 50 years old and older in Canada. And there's two different types of AMD. They're called dry AMD and wet AMD. With dry AMD, you can see a dry AMD as sort of the normal process of general aging, and it's most 90% of people with AMD would have dry AMD, and it progresses extremely slowly, and it's characterized by something called Drunsen. So on this image, you can see an example of that. There's a little spot in the retina, and this is an example of a hard Drunsen. A hard Drunsen is usually just like a lipid deposit that's on the retina, and it is a marker of progression of dry AMD. And eventually, if this gets worse, it turns into it goes from a hard Drunsen to a soft Drunsen, and the real problem becomes when you start seeing presence of a soft Drunsen. Unlike the hard Drunsen, where you have a defined border, like in the image, a soft Drunsen won't have a really definable edge. It's just kind of diffused around the retina, and oftentimes what that means is it's likely going to progress to wet AMD, and so that's good to know. So the key takeaway here is dry AMD can be a normal process of aging, and the vision loss and this kind of the symptoms is more progressive. It's more slow and gradual. And if that gets worse, it turns into a wet AMD. And so the Drunsen that I just mentioned is only associated with dry AMD, but after it progresses and develops the soft Drunsen, then it can progress to wet AMD. And what wet AMD is, it is abnormal growth of a new blood vessel, and it's responsible for serious vision loss. The progression of wet AMD is much more rapid, and this needs to be treated in a timely manner. So when you have patients with wet AMD, what that means is because there's a lot of new blood vessels that are growing underneath the retina, these new blood vessels are sort of weird, and they're very leaky, and there's like an accumulation of fluid behind the retina, and that causes a lot of damage. And oftentimes these patients, they need to get medications injected into their eye, and we'll be looking at some examples of those medications very soon. And so now that we looked at different types of AMD, we look at risk factors. Who are likely to be, which individuals are likely to develop AMD? Aging, greater than 60 are generally a higher at risk people, and people who are smoking. Smoking is actually the highest the most significant risk factor in developing AMD and progression of AMD. So that's really good to know. So I'm just going to bold that. And Caucasians have higher risks, and family history, genetics, people with hypertension, and this makes sense because oftentimes people with hypertension also have other at the end of the day, AMD is more of a vascular disorder, so it makes sense that hypertension would be a risk factor. And again, other cardiovascular disease is a risk factor. And let's look at clinical presentations. And this is probably the most important part. You will not be asked in the PBC to diagnose any kind of medical conditions, but you should have a rough idea of what the patients would present to you with, what kind of symptoms they would present to you with, and so to be able to know if this person needs a referral or not. And so in this case, early AMD is asymptomatic and is painless. However, one really obvious marks of someone with AMD is they have a loss of central vision in one or both eyes. And so in this photo, they kind of lose their visual acuity at the center of their visual field, and they have like, in a really bad case, they would have like dark patch called scotoma, and that'll definitely impact their daily routine. And usually people with advanced AMD are at high risk of depression. The interesting thing is that in the early AMD, it's asymptomatic and painless, and so it's very important for them to get healthy individuals to still get annual eye exams to make sure that they're not having any changes in their visions. And so, yeah, this is more of a clinical presentation. It's more relevant to the patient and you as a pharmacist. But diagnosis, this diagnosis, you don't have to know everything about the diagnosis component. All you really have to know is that there are scopes that physicians, optometrists can use, and there's some dye that can be injected into patient's eye, and they can take photographs of the retina and to look for abnormalities, and other type of imaging, optical coherence tomography, that can be used for diagnosis. But I think one type of test that's more relevant to clinical practice is, as far as pharmacy goes, is have them look at an Amsler grid, because Amsler grid basically is an example I posted here. It's basically a gridded line, and it's not supposed to have these wiggles. It's not supposed to. It's supposed to be straight, but this is what the patient sees. When they see a gridded line, they see what should be a straight line. It's all gets distorted, and like I said above, they have a distorted kind of vision in the center of our visual field. They basically, what they see when they see a grid, they see this. So you can have them hold this grid up closer to than an arm's length, more of a reading distance, and they should try to be focused on the center dot, which is which you can see right here. And if they report seeing a squiggly line, or like a distortion in the center of the visual field, that's usually a telltale sign that the patient has AMD. Okay. Oops. So let's look at therapy. There is non-pharmacological therapy, which is to avoid and quit smoking, which I said was the highest risk of developing AMD and progression of AMD. It's a major risk factor. So that is the single most significant thing that patient can do. And also to regulate blood pressure. As we said, hypertension is one of the risk factor. Also cholesterol level and exercise, balanced diet. This is something that everybody should be doing. And the Amsler grid, not only it's good, useful for diagnosis, but it's also useful for self-monitoring by the patients. So they can monitor themselves, see if it's getting worse or if it's getting better by keeping that on hand and just monitoring themselves. And finally, let's look at pharmacological therapy. So for both dry and wet AMD, we can use a vitamin. It's basically it's a formulation. It's a combination of different types of vitamins. It's not called Arids. It's called Vitalox Advanced. But the Arids is the study that was done to that resulted to a formation of Vitalox. And what it contains, the first formulation was called the Arids 1, and it contains copper, zinc, vitamin C, and D, and also contains beta carotene. And then they did the study again, and they came up with a Vitalox Advanced Arids 2, and it is Arids 2. The only difference between Arids 1 and Arids 2, Arids 2 also has copper, zinc, vitamin C, and D, but it also added omega-3, 6, and zeaxanthin, and lutein. And these four are the new stuff that was added to Arids 2. The other difference is that they have in Arids 2 they lowered the zinc dose, and they turns out that low dose zinc is just as effective as the higher dose of zinc that was used in Arids 1, with less side effects. So that's another difference. And the last difference is that Arids 1, like I mentioned before, had beta carotene, but beta carotene actually increases the risk of lung cancer, they realized. And so beta carotene was removed in Arids 2. However, even if Arids 2 doesn't have beta carotene, it's important not to have the patients be smoking while taking Arids 2. So when they're diagnosed with the Arids, when they're diagnosed with AMD, and they're also taking Arids 2, they actually have to quit smoking, because even if it doesn't contain beta carotene, it seems to increase risk of lung cancer in these patients. So that's an important thing that you should know when you're counseling patients. And so Arids 2 contains copper, zinc, vitamin C, D, and then omega-3, 6, zeaxanthin, and lutein, and it does not have a beta carotene. That is the difference between Arids 1 and Arids 2. Okay. And before we go on to the wet AMD treatment, I think it's important to mention that yes, Arids supplements can be used in both dry and wet AMD, but as far as pharmacotherapy goes, that's it for dry AMD. There's no other pharmacological treatment that you can give for dry AMD other than the Arids 2. So that's important to know. When we get to wet AMD treatment, that is, we open up, there's a whole host of options that we can go with. So the first line therapy for wet AMD is something called vascular endothelial growth factors inhibitors. And we mentioned initially that in wet AMD we have these abnormal leaky blood vessels that are forming, and but this medication prevents the formation of these kind of abnormal blood vessels. That's why they're called vascular endothelial growth inhibitors. So first medication we have is bevacizumab. It is a recombinant humanized monoclonal antibody, and it is used off-label actually, and it was actually originally used for colon cancer, but now it's used off-label for AMD. And it's important to mention that I'll be calling this class of medication VEGF. Right here, VEGF is an intravitreal injection. It is actually injected into the eye, and I believe it's like a once every month or once every 3-month injection. And so this type of injection, obviously it's gonna be painful for the patient, but before we give the injection, we often give them like a local anesthetic to minimize the pain. So bevacizumab is like the first thing one of the first line. And the second line, this is still also first line, ranibizumab. This one is just a fragment of bevacizumab, and so they're basically the same thing, except it's like a smaller fragment of the antibody. And the third medication we have is aflibercept. This is a recombinant fusion protein, and the last one is pegetinib. And so the most important thing is these medications are all potentially first-line therapy. However, they do not, because of that, they do not prioritize over one another. They're all, you can say that they're all equally efficacious. So that's good. The most important information when it comes with VEGF is the side effect. The side effect of the VEGF is that it's very common to get subconjunctival hemorrhaging, which is a fancy word for just redness, because you are injecting foreign material into their eye. And dry eyes is also very common, but oftentimes they resolve spontaneously. And it may, because you're injecting material into their eye, their intraocular pressure is likely going to increase. And one of the rare side effects of VEGF is endophthalmitis, and it is has more of a medical emergency, but it is extremely rare. It's basically the inflammation of your eye, and so that's something that you as a pharmacist should be aware of. Even if it's a rare side effect. And I just briefly talked about the local anesthetic for these before giving these injections. And the most commonly used is the povidone iodine. But if patients are allergic to povidone iodine, they can use chlorhexidine. And so those two are the local anesthetics. And then the last medication that we have is verteporfin. Verteporfin is a type of a photodynamic therapy, and verteporfin is a drug that is injected into as an intravenous injection, and it is highly photosensitizing. And the purpose of doing this is, after this drug is injected into the body, when it gets to the eye, it reacts with a light that you shine into their eye, and it creates free radical with oxygen, and it impairs neovascular endothelium. It impairs like a new blood vessels from forming, those dysfunctional blood vessels that's causing wet AMD, and it can actually help prevent the progression of the AMD. It is unfortunately not used first line because of it has a pretty nasty side effect. But sometimes it can be used in combination with VEGF in wet AMD. Some side effects of verteporfin is you must avoid bright light for 48 hours after treatment because of light sensitivity. If you don't avoid light for 48 hours, it can lead to a severe burn. That's how photosensitizing it is. And it'll react with other photosensitizing drugs such as tetracycline, as it is notorious for causing burns. And I think the last thing that I wanted to really point out that's pretty significant These medications, VEGF, here, can actually not only do they prevent the loss of the vision, they can also restore vision loss that has already happened to a certain extent. So that's a really good thing, and that's one of the reasons why uh, um, these medications are first line. And um, compared to the benefit that they provide, the risks also is outweighed. Um, and so that's the most important thing you should take away um, from this lecture is all the information, the vitamins, the Vitalux, and then the VEGF inhibitors. Okay, well that finishes the topic of age-related macular degenerations. If you have any questions, post and comment down below. And if you would like to see more contents like this, please subscribe and like. Thank you very much.